Hi guys, I hope. Hello. Okay, so I hope you all are doing good. I haven't been able to take your sessions because I was busy traveling to United States. I am currently in United States, so I'm sorry if the timings were adjusted in accordance to me. I'm really busy during the morning, so I barely get time. All right, okay. So we will be starting our U World. I don't know how far along you guys are, but how is your preparation going on? Is it going good? I need you to unmute and tell me how's your preparation going, or if you need help with anything in particular. No? Nobody? Guys, they're like,
Yeah, it's going good, but we were missing you because there was no Jewel session was going on since last 2 weeks.
I understand. I apologize for that. My residency starts next week. I'm really preoccupied with the onboarding process. There's a lot of stuff to do when you move to a different country. So I apologize for that. But we're getting back on track. So just with me. All right. Okay. Dr. Ahmed already said that you guys have started renal, right? So let's start renal. Okay. All right. All right. Is there anything in particular you want to discuss with me? No? All right. Okay. Let me start with the acute kidney injury. All right. All right, is my screen? I think my screen is visible. All right, okay. So the first question is the apical impulse is palpated in the sixth intercostal space along the left anterior axillary line. NS3 is heard on cardiac auscultation. Bibacillar crackles are present. Distal extremities are cold. Okay, what do you feel that is wrong within the labs? What's wrong? What's
The blood urea nitrogen is too high.
all right, okay. So what is the ratio? Is it greater than 20 or is it lesser than 20?
It's greater than 20.
Very good. All right. So if it is greater than 20, then what does that mean?
It means it is the pre-renal cause of azotemia.
Very good. And if it's going to be lesser than 20, then?
Then it's the intrinsic cause,
Very
means
good.
renal.
All right. What happens to the fraction excretory sodium in pre-renal?
In pre-renal, the fraction excretion of sodium will be less than
All
less
right.
than 1% because the kidneys function is proper and the kidneys are reabsorbing the sodium. There is no, that's why the excretion will be low.
All
While in
right.
case of renal intrinsic cause, the fraction will be more.
All right. So the guidelines have changed. Now we don't say that FENA is less than 1. We say that FENA is less than 2. So now we say that if it is less than 2, then it can be a pre-renal cause. All right. What are the two high-yield causes for pre-renal acute kidney injury?
Dehydration.
Heart
Right.
failure,
Dehydration, acute blood loss, anemia, still dehydration.
Very
And
good.
yeah.
Yeah. All right. anything that is reducing the volume within the body, it is pre-renal. All right, be it blood loss, be it dehydration, anything that is reducing the volume in the body, it's going to be pre-renal. All right, what are the two high yield causes for post-renal kidney injury?
Post-renal, because of stones or because of obstruction in old age due to BPH
Mm-hmm.
or any neoplasm can also cause the obstruction.
Very good. Anything that is, obstructing the urethra or it is either pressing on it can cause a post-renal kidney injury. So pre-renal is, anything that has a volume loss, and in post-renal, anything that is obstructing the urethra. Anything in between it is the intrinsic kidney injury. All right. Again, what are the causes of intrinsic kidney injury? It can be a lot of things. It can be drugs. It can be, the pre-renal can precipitate to intrinsic kidney injury as well. So it can be any radio contrast dyes, it can be ischemia, it can be some toxins as well. So it can be a lot of things. All right. In this case, whenever we see a lab, first of all, we need to do BUN divide by creatinine and kind of figure it out if it is pre-renal or post-renal. Now we know that if it's greater than 20, so it means you're talking about pre-renal. All right. Now then we again go to the last line and see that what are they asking? Which of the following is most likely to be present? All right. So we know that it's pre-renal, and what happens in pre-renal? We already talked about it. So what will be the answer in this?
Only the correct will be the increased proximal tubular sodium reabsorption, because the decreased, it will not be the cause. It is not decreased, it will be increased because the kidneys are functions are normal. Yeah.
Yeah. So we know, okay, if we kind of go and read the question earlier, so they were talking about a patient who had SOB. The patient had a brief upper respiratory illness, but they began developing dyspnea. What is going on? Okay, so they say that the patient had an upper respiratory illness, and then he started to develop dyspnea and probably heart failure. What's going on? Why? What happened to the heart?
I think the
Right side
patient
heart failure. Heart failure.
Heart failure is there.
Yeah.
patient is in heart failure and he's
What
decompensating.
condition precipitated heart failure? Is it myocarditis?
Yeah, dilated
Oh.
dilated cardiomyopathy
It can be myocarditis. Let me
from
see.
there.
This
Because
myocarditis.
if the right and left both heart failure is there, bibasilar crackles are also there,
Yeah.
and edema
So
also there.
exactly. So from dilated cardiomyopathy, the patient developed viral myocarditis, and that is why this decompensatory vicious heart cycle has started. If you see that the apical pulse is palpated, all right, not relevant. Bibasilar crackles, congestive heart failure. If you kind of do this, then of course the kidney is going to compensate for that and increase proximal sodium tube reabsorption, and that is why we have FeNA less than 2%. So over here, again, it is set in 1%, but on USMLE step 1, 2, and 3, it's most likely they're going to give you, if it is 1.7 as well, then that's also pre-renal. All right. Don't get confused if in the textbooks you've read that it is less than 1%, and when you see if it's 1.7, you can get confused, right? But we take it less than 2%. All right. All right. Okay. Next question. So we start reading from over here. Laboratory study revealed elevated sodium, BUN, and creatinine levels, which were within normal limits during a recent office visit. Urine microscopy shows no sediment, a primary injury to which of the following structures is most likely cause of the patient's acute kidney injury. All right, so we have a 48-year-old woman. She comes to the ED with worsening headache, blurred vision, and nausea for the past several days, decreased urinary output. Okay, BP is really, really high. There's also skin thickening. What is this condition called? Very easy. What is happening to her?
Systemic sclerosis. They have
Systemic
they have
sclerosis.
given the history, medical history significant for systemic sclerosis.
Mm-hmm. All right.
Diffuse skin thickening.
What is this called? Thickening of the hands, face, and interior chest. What is this called?
Diffuse
Scleroderma.
All right.
scleroderma.
So we have elevated BUN and creatinine. What are the two most complications of scleroderma? What does it affect more?
Pulmonary, like pulmonary fibrosis.
Very good. Pulmonary and kidney. So it affects two important things that we are worried about, and that is the lungs and the kidney. All right. Okay. Urine microscopy shows no sediment. All right. Okay. So what is it affecting? What is the scleroderma affecting?
Systemic sclerosis actually affects the systemic vessels.
Hmm. Yes, it affects the systemic vessels,
Small renal vessels.
small renal vessels.
Oh,
All right. Okay. So we know that SRC, that is scleroderma renal crisis, like I said, we are worried about two things. We are worried about scleroderma renal crisis and lungs. Thankfully, due to the recent advancements, scleroderma renal crisis is not the number one leading cause of mortality in patients. Now we're more worried about the lungs because modern treatment has evolved over time, and we have better medications to support scleroderma renal crisis. So now it is not a big major problem, but it still remains one of the major problems within the scleroderma. So what it does is that it's because we know that it is immune mediated. So it is causing immune mediated injury to the small renal vessel. It does not do that to the large systemic vessels. Why? Because if it would have been large systemic vessels, you remember Takasio's arteritis. All right. So there was this Takasio's arteritis and giant cell arteritis. Those were the large vessels that were involved. Scleroderma is not known to affect that. If you kind of see it over here, you can see this over here. The vasculitis, of the large systemic vessels, that is findings in Takasio's arteritis, like I said, and it's not linked to scleroderma at all. So over here, small renal vessels, it affects that, and as a result, it causes reduced renal perfusion. As a result, it is causing narrowing and obliteration, and most likely hypertension, and that is why hypertensive renal crisis is one of the major causes of death in scleroderma as well. And the second is SLE. So SLE and scleroderma, they both have major mortality things similar. All right. Okay. Next question. Okay, what is wrong with the labs? What is wrong with the lab? What is the BUN?
Creatinine is elevated for this
Okay.
lab. BUN is also elevated.
All right. Is it greater than 20, lesser than 20?
It is. Let's see. It's greater than 20.
Yeah, that's
It's greater than
right.
20.
So maybe they're talking about pre-renal. All right. Dry
Yeah.
mucous membranes, dehydrated. All right. Blood pressure is okay. Pulse is okay. Everything is okay, but she's had dizziness. She's had watery diarrhea. Okay, so probably there's volume loss diarrhea, and she's dehydrated, and that is why she's having pre-renal kidney injury. Which of the following changes are most likely to be seen in the patient? All right. So if the kidneys are hypoperfused, then what happens?
If the kidneys are hypoperfused, there will be increased GFR. Okay, in regards to vasopressin, so the RAS
system. Yeah, RAS
RAS
system will
system
be activated. RAS system will be
deactivated.
activated. So
There will be increased
epinephrine,
vasopressin.
norepinephrine will be increased. Aldose and the vasopressin
Vasopressin
will
increased.
be increased.
Epinephrine
Angiotensin 2 will be increased. All these things will be increased,
I
while
think
the
all are increased.
endothelin 1 will be
Increased because
It will be
will
increased
also
as
be
well.
increased. I think
And the
everything
will be
will be
increased.
increased. Yeah.
So we'll go with A.
All right. Okay. So A. Okay. Let me see. Yeah. All right. So what is happening is, so like I mentioned, that the patient had gastroenteritis. Again, there is hypovolemia going on. Hypovolemia, kidney becomes, hypoperfused, and as a result, RAS gets activated. When RAS is activated, we know that angiotensin 2 is going to elevate, and that is going to, kind of stimulate the release of aldosterone and endothelin 1. Again, what they do is basically that they increase sodium and water reabsorption and SPR, so that they can kind of help maintain blood pressure, because the kidney thinks that, oh, if the kidney is getting hypoperfused, then that also means that the blood pressure is dropping, and that is why it does like physiological changes within the body so as to maintain the blood pressure. Vasopressin, ADH, we know it is released by the posterior pituitary, and that it also is released in response to increase serum osmolarity or decrease systemic pressure. Again, so what RAS does is it increases sodium and water reabsorption via angiotensin and aldosterone pathway, also while increasing the blood pressure in response to hypotension. And that is why everything over here is going to get increased. Nothing is going to get decreased, all right? Because the body is in the fight and flight mechanism. So everything is going to get increased. Nothing is going to decrease. All right. See, sympathetic tone. So it is fight and flight. You need everything. So everything is going to be increased. That's an easy way to kind of help you remember this. All right. Next question. Today he has elevated BUN and serum creatinine levels. Okay, the patient has no fever, blood pressure, heart rate is normal. Physical examination shows no new findings. All right, so they're asking what changes would be present in the patient's kidneys. So there's this man who was evaluated due to acute renal failure. The patient was hospitalized 3 days ago. Okay. During admission, he was found to have an increased trophi, but there were no STEMIs. And what else? Okay, injection of contrast dye was also given to the patient. Okay, so that's a red flag. All right, okay. The patient is continuing to receive treatment. All right, okay. So he was given a contrast dye, and after that, he's having the increased BUN and creatinine. What is probably wrong? Very easy.
Patient has a contrast-induced nephropathy.
Very good.
Mhm.
So what does it cause?
It would cause
ATN. That causes
ATN.
the
ATN. So our answer would be A.
Necrosis.
A.
All right, okay. So we know, okay, where do you see fibrin-like material lining the arterial walls?
Vasculitis.
So that would be
So in polyarthritis nodosa, there will be fibrinoid.
Vasculitis, like any
Yes.
vasculitis, I think.
Yes.
okay. Yeah.
Very good. Okay, so this was contrast-induced nephropathy. Majorly, they will give you something like muddy brown cast on urine analysis. The treatment for contrast-induced nephropathy is to do nothing. Literally, it is to do nothing. So the kidneys have this, ability that they're going to repair themselves once you remove the trigger or the toxin. So post nephropathy, post contrast dye, if the kidney is having increased BUN and creatinine, after a few days, it's going to go back to normal. So the thing is that, just hydrate and do nothing. See, if you just kind of see this over here, that it returns a gradual return to the baseline, like I mentioned already. So do nothing. Again, it's one of the reasons that they mention it on the USMLEs as, acute kidney injury, a part of acute kidney injury. This is very high yield muddy brown cast on urine analysis. They love to throw it. The urine analysis pictures sometimes are going to say, oh, you have 3-4 RBCs, but they say that you don't have cast. All right. So children usually confuse RBC cells with RBC casts. They two are different. All right. I want you to know that. So whenever they say on urine analysis that the patient had 3 to 4 RBCs, all right, that is different than saying 3 to 4 RBC cast. Whenever you have cast, then that means that that's any sign of kidney injury. But whenever they mention RBCs, that normal red blood cells, that is normal. Sometimes you get RBCs in the urine as well. That is normal. But cast is something that is abnormal. All right. So be able to differentiate in both of them. They aren't the same thing. And I've seen students getting confused with both of them. And they say that, oh, the patient is having hematuria, and the patient is not having hematuria. He just had 3 to 4 red blood cells. That's it. All right. So have that sort of differentiation. Again, fibrin-like material, you guys said it wrong. I wanted you to mention fibrinoid necrosis. It is one of the most, high-yield things that they want to ask you. Fibrin-like material lining the arterial wall, that's fibrinoid necrosis. I don't know if you remember this when we were doing the first chapter of pathology, and we were discussing different types of necroses. Fibrinoid necrosis was one of that, and this line is actually mentioned in the pathoma as well. All right, if you kind of go down, that's what I already said, that it returns to the baseline. You don't have to worry about anything. All right, next question. Okay, what is wrong with the lab?
Hemoglobin is low for this
Okay.
patient. BUN is elevated, creatinine elevated,
Elevated.
and then albumin is
Albumin is elevated.
Total proteins are also highly elevated.
total
Yes.
8.9.
8.9, yes.
All right. Okay. So what are they saying? Okay. Renal biopsies performed shows atrophic tubules. Okay. Vaxi cast that stain intensely with eosin. Okay. Back pain, constipation, easy fatigability. All right. Dry mucous membrane. Okay. All right. What's wrong? What happened?
Yeah.
um,
Let's say atrophic tubules. It's also the kidney injury because of the because of the proteins level is high. That will be seen in multiple myeloma. And
I've
but the
highlighted
vaccine,
persistent back
once
pain.
it passed, just
Vaxi
shows
cast.
kidney injury.
Mention 2 to 3
What's the
things.
cast
Alright.
coupled with the back
So
pain?
back pain.
Back
What does
pain.
that mean?
back
The
pain.
patient is taking what?
Yes, the old man with the back pain, persistent back pain.
What
So
is the
Patient shows
what back pain?
hypercalcemia.
mhm.
You guys are going in the wrong direction. I'm saying that the patient is having back pain. What
There are
does
the two causes of the persistent back pain in old man. The one is the prostatic mets and other is the multiple myeloma.
mm-hmm.
So we should keep in mind those things. And then if there is the protein value is very high.
All
So
right.
protein values are high and the vexicast is also there. So it leads that it means that there is end stage renal disease that
Mhm.
leads to amyloidosis, and amyloidosis is seen in the multiple myeloma.
Okay. So we agree with multiple myeloma.
Yes.
Renal insufficiency. Yes.
All right, very good. Okay, so first of all, back pain, I said bone pain is a very important feature of multiple myeloma. Remember the crab mnemonic. So you have hypercalcemia, renal problems, anemia can also be a problem for that. Bone pain is one of it. So that's crab mnemonic. So we have, again, the other thing is this gamma gap that, sometimes I'm not able to differentiate between if the total protein is high or albumin is high. So there's something we do that is a gamma gap. What we do is that we minus both of them, and whatever the answer is, if it is greater than a certain limit, like over here, if it is greater than 4, then that means that they're talking about a gamma gap, and that's usually seen in multiple myeloma. Because so what you do is you minus total protein with albumin, and if the answer is greater than 4, then that means there is a gamma gap. All right. Again, there's this Ben-Stone's proteins that are present. There are eosinophilic cast also seen over here. If you kind of go down again, they talk about that. What is the treatment for multiple myeloma? What do you give?
Steroids.
Lenalidomide,
What else?
daratumumab, dara, and dexamethasone.
Okay. What else?
Bortezomib.
Yeah.
Plasmapheresis, we do the
Very good.
plasmapheresis, and one is the monoclonal antibody rituximab. That's also the one.
Bortezomib.
Bortezomib is what they want you to know. Bortezomib is, what does it do? That is, it inhibits proteasomes, I think, if I'm not
Yeah,
wrong.
it's proteasome
Yeah,
inhibitor and
it's a
causes the
proteasome
apoptosis.
inhibitor. Yeah. So what it does is that it interferes with the function of proteasomes. So those are basically cellular structures that are responsible for kind of like breaking down unwanted or damaged protein. So when you kind of block the proteasome activity, what it does is that it causes an accumulation of proteins within cancer cells, ultimately causing them to die. All right. So that was like how it works. What USMLE wants you to know bortezomib is in terms of multiple myeloma. All right. They have also asked this in the treatment of multiple myeloma. So pick bortezomib. All right. Rest of the things, rituximab can be the answer too, but first line is always bortezomib. If you don't see bortezomib on the answer stem, then go for rituximab. All right. Okay. All right. Next question. Serum creatinine level is 2.4 and urine sediment microscopy. See, that's what I said. That sometimes they make like, these RBCs and CAS are two different things. All right. 3 to 4 red blood cells. The pathologic process affecting this patient's kidney most likely involves which of the following structures? So we have this man, he's treated for bacterial sinusitis with ampicillin, and then later he comes with fever and a skin rash, low urinary output, diffuse maculopapular rash. So what happened?
SLE. SLE is here, and SLE caused the papillary necrosis.
That's true. What else?
Renal papilla will be involved.
No, it is
I think
the
ampicillin
No,
can
it
cause
was
See,
due to virus.
the interstitial,
creatinine.
renal interstitial injury. It's the acute interstitial nephritis.
Yes, SLE can cause both. It can also cause the papillary necrosis as well as interstitial nephritis. Yes.
That is true. If you kind of see, the temperature is also really high. In papillary necrosis, two most important causes are sickle cell and diabetes mellitus. So they usually don't say this in terms of SLE. They want you to know that in terms of sickle cell and diabetes mellitus, renal papillary necrosis. So acute interstitial nephritis, like I said, there are a lot of drugs that cause interstitial nephritis. Over here, the drugs that are not mentioned is cisplatin. Cisplatin also causes interstitial nephritis. Write it down or remember it, memorize it. Cisplatin, and then certain antibiotics, rifampin, cephalosporins, they love to ask in terms of interstitial nephritis, cisplatin, so certain PPIs and NSAIDs, rash fever. It's usually asymptomatic. Usually acute interstitial nephritis will kind of present like that, oh, the patient was started on a drug, and after a certain amount of the drug, they started having, this fever and, WBC and, all of that in the urine. And most likely it's an acute interstitial nephritis going on. Again, if you kind of see in the kidney biopsy, there are inflammatory interstitial infiltrates and edema over here. And the most likely are referring to the same thing. If you kind of see renal papilla, again, it is common in sickle cell diabetes mellitus. So most of the times they want you to know that in terms of sickle cell and diabetes, nothing much. All right, okay. Next question. All right. After 24 hours of therapy, urine output is increased and BUN declines towards normal. Which of the following additional laboratory abnormalities suggest that this patient's initial oliguria is a compensation for volume contraction? All right. So if this patient was in a motor vehicle collision complicated by severe hemorrhage, all right, he was given aggressive IV fluid hydration. What's wrong?
I think because of hypovolemia, patient has prerenal azotemia.
All right. What else has he got?
Yeah, I think they're pretty much talking about pre-renal azotemia for these patients because patient has severe hemorrhage. So we're talking about acute blood loss. So in pre-renal azotemia, we already did mention earlier that we have BUN creatinine ratio of greater than 20. We have urine sodium less than 20. So answer I'll be looking at E. Then we also have urine osmolality greater than 500, I believe. And then just a
How
last
else
one.
can ischemia occur?
Everything is
I think the answer is E. Urine sodium less than 20.
All right, I want you to tell me how else does ischemia occur?
For this patient, so the patient had motor vehicle collision and has an acute blood loss anemia. So when this is ongoing, there's reduced renal blood flow, reducing GFR, and then increasing creatinine.
All right. Okay. So what do you think the answer is?
I'm going for E. E because I believe we're talking. This is pre-renal azotemia. So with all the features for pre-renal azotemia, urine sodium is less than 20. That's the next routine.
Okay. All right. So E. Okay. Let us put E. Yeah. So acute kidney injury, we know we talked about that already. Pre-renal and acute tubular necrosis. In pre-renal, it is decreased renal perfusion, hypovolemia. So we already talked about this. I'm not going to go in great detail. But the patient had acute renal failure. How did we know about that? Low urine output, high BUN after massive hemorrhage. Like I said, anything that causes volume loss, it's most likely it's going to be pre-renal. So what you do is you try to replenish the volume loss either by hydration or by kind of giving blood to the patient if the patient is severely severely has a lot of blood. If you kind of see over here, again, they talked about BUN. They also talked about this other thing, high urine osmolarity. What does that mean?
High urine.
Patient and sorry. I think patient has hypovolemia, so RAS system will be activated. So body wanted to retain water, and urine will be more concentrated because of that.
Yeah, that's right. All right. Okay. So if you kind of go down, we again talked about the same thing. Sometimes they do ask about urine osmolarity, but not always. But you should be able to differentiate that what is happening in pre-renal, what is happening in post-renal in terms of urine osmolarity, because sometimes they do ask you about that in terms of arrows. All right. Okay. Next question. What's wrong? Okay, FEN is greater than 2%. Where do we see that?
Yeah, so the sodium excretion is more than 2%. That's we see in the interstitial renal failure, if the renal is the cause. So
Yeah.
there is also the granular
Intrinsic
cast,
cause of renal.
ATN. So intrinsic cause. So and the granular cast also indicates that it's the renal intrinsic cause.
Yeah.
So we can read the question. Gentamicin. So aminoglycoside induced.
Yeah.
Yes, aminoglycoside can cause the ATN. It is one of the cause of ATN. And multi-drug resistant. The patient has remained afebrile, blood pressure normal, and the examination shows moist mucous membrane and there is no rash. So it will be ATN, tubular necrosis.
It's the A one.
uh,
Focus.
Yeah. So again, aminoglycosides, vancomycin, farnesacnate, C cisplatin. That is why I already told you in the previous question before. Cisplatin causes. Sometimes cephalosporins can also cause it. So try to remember that as well. And if you kind of go down again, they're talking about the same thing, that it's going to cause proximal tubular injury. The reason that it kind of affects PCT is because it responds to hypoxia severely. So in terms of ischemia as well, it is going to affect PCT first, and in terms of damage, toxin damage or drug damage, it is still going to affect PCT. So PCTs are very vulnerable to less oxygen or hypoxia, and they're the first ones to shed. All right, that is why you always see focal tubular epithelial necrosis of the PCTs first, and then over time you're going to see that for the rest of the kidney as well. Okay, so if you kind of go down again, talk about the same thing. Okay, next question. All right, okay. Supportive care is provided. Several days later, his urine output significantly increases and serum creatinine levels decline. Over the next few days, this patient is the highest risk for which of the following complications? All right, so this patient was brought to the ED because he was vomiting a lot of blood. After the resuscitation, he undergoes for GI endoscopy, which reveals a bleeding duodenal ulcer. The patient develops decreased urine output. All right, okay, so basically after an endoscopy, he had like decreased urinary output and his creatinine levels rise. There's patchy epithelial necrosis of the tubules and intratubular cast. Why is it happening, and what is the risk of complication?
This patient is at risk of complication of hypokalemia.
Why?
So this patient has been vomiting blood, and presented with and was started with supportive care. So in this case, if I have to do my elimination, patient has already started supportive care, so there's improved symptoms has improved, GFR creatinine is improved, patient is currently making urine, so that's really my volume overload. So for urine protein loss, we're not talking about glomerulus or problem with glomerular, we're talking about the tubular problems, and urine protein loss is usually associated with glomerular problems. So I'm taking off that one. The same mechanism I'm thinking for metabolic acidosis goes with my urine volume. So my only leftover will be hypokalemia. Now in hypokalemia, for a patient that has been losing electrolytes and then was vomiting, came to the hospital supportive care for days, usually I know that they come down with reduced potassium in blood because there will be increased. Okay, so there is potassium loss. So potassium is not reabsorbed because sodium is reabsorbed and potassium is replaced. I'm trying to use my more confident word, is replaced with it. So increased reabsorption of sodium and then potassium is lost in urine. The patient is at risk of hypokalemia.
And you are right. Okay, so what happened was that there are stages to acute tubular necrosis. So this is the initiation stage, you have the maintenance, and you have the recovery stage. So what happens in the initiation stage is, first of all, either ischemia occurs or whatever the offending agent is, it induces damage. In the maintenance is the kidney a kidney starts to respond to the changes. For example, first of all, you become symptomatic. There's decreased GFR, decreased urinary output, and you have increased creatinine and bun, increased urine potassium and phosphate, and it's going to cause metabolic acidosis. All right, if you kind of remember it in terms of what normally kidney does, is that it excretes out potassium, right? That is what the main function of the kidney is number one, that it excretes out potassium. So if the kidney is not going to work properly, then what happens? The serum potassium levels will go.
There will be hyperkalemia then, because
Yeah.
the kidneys secrete the potassium and potassium excretion will not be there, and hyperkalemia will be in that case. But here in the recovery phase, when there will be polyuria, so the imbalance, electrolyte imbalance will be there, and the risk of hypokalemia will be there.
Yes. So again, in the recovery phase, we know that when there's going to be increase in the urinary output, there's going to be high volume diuresis, and as a result, what is happening is this electrolyte wasting. So in the maintenance stage, you will have hyperkalemia, and the recovery stage where you're going to be having, a lot of diuresis going on, then of course the potassium is going to get flushed out, and that is why you're having hypokalemia. What are one of the major symptoms of hypokalemia? How does it present? How does hypokalemia present?
Muscle weakness, muscle spasms, patient will be lethargic.
Weakness.
You can have a
Weakness.
You can have weakness, muscle spasms, weakness,
Yes. Mm.
lethargy. Patient may be fatigued as well.
Very good. Remember that any increase or decrease in potassium is gonna get problems within the heart. All right. So if the level gets disrupted, it's gonna cause arrhythmias. Even if it's gonna go high, even if it's gonna go low, both of the conditions, it's gonna disrupt the heart and it's gonna cause arrhythmias. That is the number one thing we're worried about in potassium. All right. Heart problems is the number one thing we're gonna be worried about. Second, of course, it's going to present as muscle weaknesses, and that phosphate also presents as muscle weaknesses. But the heart is what we're most worried about in terms of potassium. All right. Okay, if you kind of go down, again, we're talking about the same thing. So these three phases are really important for you to kind of memorize and kind of know what happens in what stage. All right. Okay. Next question. Oh, okay, arrows. All right. Urine analysis reveals concentrated urine with a specific gravity of 1.030. Which of the following changes in renal plasma flow, GFR, and FF are most likely to be present? All right, okay. So there's this 72-year-old man. He has been, doing diarrhea and vomiting for the last 24 hours. He hasn't been able to take much fluid. He has hypertension treated with hydrochlorothiazide. Blood pressure is very low. He's extremely dehydrated. What is going to happen?
A.
Yes, because the renal plasma flow will be much decreased in case of dehydration. And the filtration fraction is equal to GFR divided by renal plasma flow. If the denominator is decreased, so the GFR will be decreased, and the filtration fraction will be increased then.
Yes, you're right. Okay. So if you kind of go out here, you can see this over here. That when the arterial pressure drops, renal plasma flow decreases, and naturally GFR is going to decrease as well. What it will do is that it will cause afferent arterial dilation and efferent arterial constriction. And both of them will result in improved GFR, and that will cause a rise in the increase in filtration fraction. So even if you kind of see over here, we know that FF is equals to GFR over RPF, and in terms of dehydration, both of them are going to go down. So if the denominator is extremely low than the numerator, then of course the FF goes up. Again, not much to kind of talk about over here. It's basic physiology of the renal. And even in the beginning of the lectures, I told you guys that there are only very, very less subjects in which they like you to know the physiology of it. Otherwise, they really don't focus on the physiology aspect. But in terms of cardio, renal, sometimes musculoskeletal, and two more other subjects that I forgot about. Those 4 to 5 subjects they love to test you on cardio, on the physiology aspect of it. So be very sure that you know about the fractions as well, stuff like that, because they love to ask you that. All right. Next question. Ibuprofen is discontinued. Kidney function returns to normal. Which of the following best explains the transient deterioration in renal function? Okay, very easy. So this patient was started on ibuprofen, and because of the knee osteoarthritis, there's nothing on the urine analysis But as soon as she was started on ibuprofen, her creatinine was a little high, but then it goes back to normal. So, what was the reason for the deterioration?
Upfront arteriolar vasodilatation. It impairs the upfront arteriolar vasodilatation because the prostaglandins vasodilate and the NSAIDs inhibit the prostaglandins effect.
Very good. So you should know that NSAIDs, ibuprofen, aspirin, naproxen, they exert their anti-inflammatory effects through the inhibition of COX. So you should know what COX does, where it affects. We know that it affects the afferent arteriole. What affects the efferent arteriole?
The
Angiotensin 2.
angiotensin 2 effect over there.
Angiotensin 2
Very good.
and yeah.
Very good. All right. Okay. So again, we knew about that. If you kind of go down, again, they're talking about the same thing. NSAIDs that inhibit prostaglandin synthesis. It can again cause pre-renal azotemia. Anything that is decreasing the volume or is anything that is affecting the afferent arteriole also can also cause pre-renal kidney injury. Kind of makes sense because uh, it's before the kidneys, right? Afferent arteriole is before, and efferent is after. So it kind of makes sense in terms of that as well. All right. Next question. Examination shows mild lethargy and delayed capillary refill, or the BP is extremely low. Which of the following physiological changes in kidney function would be most likely in the patient? All right, so there is this patient who comes because of acute bright red blood from the rectum. The patient had large bowel movements. He has a history of diverticulosis. All right, okay, what's happening? What's happening, guys?
There is also the blood loss, so hypovolemia, and that leads to pre-renal azotemia. Uh,
Hmm.
and the options are the decreased chloride reabsorption, no decreased sodium reabsorption, decreased urine osmolality, increased renal blood flow. No, it is decreasing, and increased tubular hydrostatic pressure, and increased urea reabsorption. Uh, because of renal hypoperfusion, the RAS will be activated. That activates the aldosterone and everything. So
I think F1.
goes in the favor of only the urea reabsorption is, or
Okay.
because the chloride reabsorption decreased, it not decreased. Urine
Because
osmolality or
urea follows the water. So I think increased urea reabsorption.
Exactly, yeah.
urea reabsorption will be increased.
So too. Thank you, Ariel.
And they asked the examination shows mild lethargy and delayed capillary refill. Means there
Yeah, it
is
shows hypovolemia.
dehydration or hypovolemia. Yes.
All right, yeah, you're right. So the patient had an acute GI hemorrhage, and as a result, hypovolemia occurred. Again, we know that signs of hypovolemia include dry skin, decreased turgor, dry mucous membranes, decreased urinary output, all of it contributing to hypovolemia. Again, activation of RAS occurs, and when RAS has occurred, aldosterone increases sodium reabsorption. So sodium and water reabsorption increases, and of course, they also do systemic vasoconstriction, which kind of increases the blood pressure as well. We know that increased urea reabsorption is also kind of mediated by ADH, which increases urea permeability. And that is why urea reabsorption occurs. If you kind of see over here, again, urea follows the water. The other thing is that it also causes increased potassium excretion. So in a normal kidney, we know that all of that is happening, and primarily the potassium is being excreted out because we don't want potassium to be in an imbalance, right? So because it's going to affect the heart. So yeah. All right. Okay. Next question. Perfusion pressure is decreased until renal tubular dysfunction occurs due to sublethal cellular ischemia. Recovery of function is achieved within several hours of reperfusion. Which of the following is most likely the earliest change to occur within the renal tubules during the ischemic period? All right, okay. So what is happening is that the researchers are kind of studying acute kidney injury in septic shock. In an experiment, the renal perfusion pressure of laboratory mice is reduced to assess changes in renal tubular function and morphology. All right, what is happening?
The initial step will be the loss
Loss
of
of epithelial cell polarity. That will be the first notable
Both
ischemic
these
change.
clumping occur late, not the initial event. And the damage to basement membrane also doesn't occur in ATN, and the activation of cytoplasmic S species is seen in the apoptosis. Yeah, see.
All right. Okay. Yeah. So again, we know that if you kind of go down, you'll see this, what's happening. If there is what the reason that we mean that loss of epithelial cell polarity is because that there is an kind of like an early change that occurs in the renal tubular cells in response to ischemia, and that is why the polarity loses. What we mean by that is that it disrupts the cell structure, and because there are specified pumps all over the cells to kind of regulate the homeostasis of the electrolytes. If it kind of gets imbalanced, then there's going to be a problem, right? So what happens is that epithelial cell polarity is lost because of the damage to the cytokines, or the cell structure is basically lost when there's ischemia occurring. All right, that is the key thing that was behind it. All right, okay. Next question. All right, what is wrong in the labs? What is the BU1 creatinine? Is it greater than 20 or lesser than 20?
Greater?
Greater than 20. It's greater than 20.
A little bit above 20.
All
Yeah.
right, so it's greater than 20. Most likely you're talking about pre-renal. All right, if you kind of go up again, you're talking about that the patient was already, had like a severe pyelonephritis thing going on. There was this E. coli as well, and she was discharged with levofloxacin. Okay, she's had nausea, vomiting. Okay. All right, okay. What's happening? She was taking levofloxacin. What is the cause of the patient's renal dysfunction?
Can we see the question again, please?
Yeah, sure.
Which drug is taking? He's taking?
CFAP.
Levofloxacin.
Yeah.
Mm.
Okay, so he had UTI and then was started on antibiotics. Prior to then, he was hospitalized 5 days prior. Okay, with fever. Okay. Okay.
All right. What's wrong?
So this is obviously not a urinary tract obstruction. I'm just going to do elimination to know which is my best response or my best answer at this point. I'm taking out urinary tract obstruction. I think this is pre-renal azotemia, actually.
Does the question say that she has not been using?
Pre-renal, the
question
initial
say-
sodium should be low.
Yeah, it looks like
This is pre-renal
intestinal
azotemia because
nephritis.
the
There's loss of
BUN
appetite, so I think she has probably dehydration. She's not eating, nausea, and loss of
Yes.
appetite.
All right.
I
What do you
think
think the answer is?
Prerenal
Yeah,
azotemia.
pre-renal, yeah. See.
Yeah.
Okay. Even if you can't understand what's going on, like I said, the first thing you do is, take the BUN creatinine ratio, and based upon that, you put and go and put the answer. Sometimes it is not necessary to kind of juggle through the options, but it's very straightforward. All right. Save time on step one, two, and three. You time is God. All right. Over there, the time flies away like in instantly. So make sure you save time and not ponder too much on straight answers. Again, if you kind of see over here, the reason that the patient was having a reduced renal function was because of a decreased oral intake, which was subsequent to hypovolemia and decreased renal perfusion, and that is why the patient had acute kidney injury. This drug does not necessarily cause post-renal kidney injury and sorry, intrinsic kidney injury. And even if it was causing intrinsic kidney injury, then you would have seen, the ratio would be lesser than 20 and not greater than 20. All right. So it was a clear indication that, okay, that they're not talking about the drug that affected the kidney. All right, if you kind of go down, again, they're talking about the same thing. And that is why it's really important for you to kind of go through everything. All right, last question for today. Peripheral pulses in the lower extremity are bilaterally palpable. Serum creatinine is 2.8. Pre-op was 1. Which of the following histopathological changes would most likely be seen on the biopsy? All right, so this patient goes for coronary angiography. He returns to the ED 2 days later with the discoloration of his right toe. He has pain, significant for hyperlipidemia and CAD. Right toe appears cyanotic. He has levator reticularis. Peripheral pulses and lower extremities are bilaterally palpable. All right, what's going on?
Because the
It's the
angiography is done, so the contrast induced injury is also this.
it's, I think,
But
cholesterol clefts in the arterial lumen. It's the
Levator
cholesterol policy.
reticularis. Levator reticularis is very, very high yield in terms of
mm,
what?
yes, yes. So the
Mm,
Cholesterol
cholesterol,
embolism.
cholesterol clefts between
Cholesterol
them
clefts,
and
yes,
them.
there it
of
is.
Yeah.
course. You see mottled skin, all right? So whenever they put levator reticularis, that's mottled skin. That means that, the blood supply is being cut off. It's getting choked. And if you choke any artery, what's going to happen? It's going to shimmer a little blood. And that is why some of the areas are perfused and some are not, right? So levator reticularis, cholesterol syndrome. Remember, it can also cause cholesterol embolies, and that is why it's causing infarcts all over the body, right? So bowel ischemia can occur, renal infarcts can occur. The reticularis means that it's basically affecting the skin. You see that this mottled appearance over here. It can cause a stroke. Can it go to the heart?
I think no.
No, only in one condition it can travel to the heart, and that is
It's ASD, atrial septal defect, or patent foramen veil.
that is right. All right. So it can go to the heart because artery and venous circulations are totally different, but the only reason that it can get mixed together or a paradoxical emboli can emerge is in terms of when there's shunting going on or there's a patent foramen valley. In those conditions, it can travel, but otherwise, arterial and venous circulations are totally different. All right. So this was it for today. If you guys have any questions for me, I can answer them before I go and I see you tomorrow.
Same time tomorrow, right?
Yeah.
Okay.
All right. Okay. I'll see you guys tomorrow.
Thank you so much, Dr.
Thank
Mahin.
you.
All right,
Bye.
guys.
Thank
Bye
you.
bye. Have a
And
great
welcome
day.
to the United States.
Have a great day, night, wherever you are around the world. All right. Good night. Good night.
Good night.
Hello. Are you guys able to hear me? Hello.
Yes, we're able to hear you.
Okay. So please don't leave the meeting. We are going to continue the session, and today we are going to discuss really important topics. That is nephritic syndrome, and along with that, we'll also be going through some of the topics like urinary tract infections. Okay. Okay. So let's have 5 minutes of break, and then we'll be starting our session. Okay. Hello? Are you guys able to see my screen? Hello?
Yes.
Hello? Okay, perfect. So yesterday last day we discussed a little bit about nephritic syndrome, right? We have completed our nephrotic syndrome section. We discussed post-streptococcal glomerulonephritis, and we were at rapidly progressive glomerulonephritis. So what is rapidly progressive glomerulonephritis? As the name indicates, rapidly progressive glomerulonephritis. As the name indicates, the nephritic syndrome can sometimes progress to renal failure, right? And this renal failure is going to be within weeks to months. Like, it's a very quick renal failure, right? It occurs within weeks to months. And the main hallmark for that, like in your dual question, whenever you see that we have an individual with some signs, and symptoms of nephritic syndrome that we discussed, like for example, blood coming out in the urine. Whenever on imaging, if he's having like crescents within the Bowman capsule, you should think of this individual have entered to rapidly progressive glomerulonephritis. That is a rapid decline of your kidney function, right? So crescents within the Bowman capsule are characteristic features of your rapidly progressive glomerulonephritis. Okay, so now the next question should arise in your mind: what is crescent in the Bowman capsule? So for example, if this is your Bowman capsule, rapidly progressive glomerulonephritis, you are going to see a crescent shape structure within the Bowman capsule. What is the composition of this crescent? It's really important. Your world is going to ask you this. Okay, so it's basically comprises of fibrin and macrophages. Really important. Okay, so you should simply think of nephritic syndrome is a kind of inflammation. We already discussed, and most of the nephritic syndromes are going to be due to immune complexes deposition. And as we already discussed, it's the job of your complement system to clear out those immune complexes from your glomeruli. So it's going to trigger an inflammatory process. And you know, as the inflammatory process is triggered, a lot of inflammatory cells are going to come to that site, right? Including your macrophages as well. So macrophages along with fibrins are going to arrange themselves in the Bowman capsule in the form of a crescent shape, which is characteristic feature of your rapidly progressive glomerulonephritis. So there are a lot of, based on immunofluorescence pattern, there are a lot of different variants of rapidly progressive glomerulonephritis, which we are going to discuss. Okay, so based on immunofluorescence, we have divided these into three categories, right? Okay, so the first categories would include, like whenever you see a linear arrangement of antibodies against your basement membrane, right? So you can see this is your basement membrane, and sometimes your antibodies are going to be, aligned in a form of linear pattern whenever you just visualize it. So that's going to be one type, right? And the disease which is characteristic of this type of immunofluorescence pattern is going to be called as Goodpasture syndrome, right? Goodpasture syndrome. Really high yield. You are going to be asked about Goodpasture syndrome, right? So my question for you guys is that if the antibodies are directly attaching against your glomerular basement membrane, which is a kind of antigen for these antibodies, so it's an hypersensitivity reaction. It's an example of which hypersensitivity reaction? Yes. Which type?
Type 3.
Type 3. It's type 2, not type 3, because we do not have immune complexes deposition. We have directly the antibodies are coming, and the antigen here is, your basement membrane. Simply you can think of, right? And they're just coming, attaching directly to the basement membrane. So it's an example of type 2 hypersensitivity, right? Type 2 hypersensitivity. But an interesting fact about it is that the basement membrane not only is present within your glomeruli, the basement membrane is also present within your, yes, alveolar basement membrane, right? In your alveoli as well. So in Goodpasture syndrome, if you have antibodies attaching to your glomerular basement membrane here as well as alveolar membrane, right? So what happens? Simply you can just imagine whenever the antibodies are present against certain surfaces. So antibodies act as opsonin, right? What is opsonin? That is all of these antibodies are going to redirect all of your immune cells or your inflammatory cells towards this side. And as these inflammatory cells come here, it would lead to destruction, right? It would lead to an inflammatory process, which is a kind of nephritic syndrome here, right? And as you have nephritic syndrome, the main hallmark, as we discussed, is going to be hematuria, right? Am I right?
Yes. Yeah, you are.
Due to inflammatory cells destroying that glomerular basement membrane. So we are going to see hematuria. But along with that, we already discussed that inflammation is also going to occur at the level of your alveoli as well. So we won't only be seeing hematuria if in the question stem you're seeing hemoptysis as well. That is blood within the cuff or blood within the sputum. So it's basically an indicative feature of your Goodpasture syndrome. And the immunofluorescence pattern, that is going to be linear arrangement of antibodies against the glomerular basement membrane. Is that clear?
Yes.
Okay, and classically it's seen in young adult male. Okay, so the second type of rapidly progressive glomerulonephritis on the basis of immunofluorescence pattern is going to be a granular pattern, right? So sometimes you can see a granular pattern of immune complexes deposition, right? Immune complexes would deposit in a form of granular form, right? Granular form. So it's an example of which type of hypersensitivity when your immune complexes are depositing there. Yes.
Type 3.
Perfect. So it's basically your type 3 hypersensitivity, right? And this granular pattern can be seen in post-streptococcal glomerulonephritis, which we already discussed. What is post-strep? Who's going to be telling me that? Yes. Hello?
It's type 3 hypersensitive.
Okay, in post-streptococcal glomerulonephritis, as we already discussed, usually seen in children, we're going to be having immune complexes deposition, a cola-colored urine. Along with that, we are going to see subepithelial humps. Okay, and another thing, do you guys remember a pathology which is known as SLE? In SLE, again, we are going to be having mixture of type 2 and type 3 hypersensitivity. But the main, pathology which is going on here is that the immune complexes are going to deposit in the various parts of your bodies. That's basically example of type 3 hypersensitivity. Okay, what is the most common cause of death in individual with SLE?
Renal cause.
Renal failure, okay, or renal cause. So these immune complexes, whenever they enters into your glomeruli, would appear as a granular pattern, right? So due to SLE, it's going to cause diffuse proliferative glomerulonephritis. That is, again, these antibodies are going to go, they are going to deposit there within your glomeruli, activating your local complement system and causing destruction there. And the pattern, the immunofluorescent pattern there would again be a granular pattern. Is that clear? Hello? Hello?
Yeah, we're here.
Okay, okay, perfect. So the third type of pattern, immunofluorescence pattern, would be aposi-immune. What do you mean by aposi-immune? In this variant of your rapidly progressive glomerulonephritis, we won't be having any immune complexes. We won't be having any antibodies there, right? But still, it is a variant of your rapidly progressive glomerulonephritis. So 2-1, which includes your posi-immune or negative immunofluorescence. Negative immunofluorescence are going to be Wagner, granulomatosis, and Church-Strauss. Okay, so in order to remember Wagner granulomatosis, there is a mnemonic, right? So let's call it as Wagner granulomatosis. Okay, why have I just called it as Wagner granulomatosis? We are going to see C. Anka. What is C. Anka? Do anyone know it? Yes. Hello.
It's anti-neutrophil cytoplasmic antibody.
Perfect. So in this case, for example, if you have a neutrophil, right? And this is, let's suppose, the nucleus of that neutrophil. Okay. So in C. Anka, basically, we are going to be having antibodies, which will be against this cytoplasm of your neutrophils, right? So it's basically known as cytoplasmic anti-nuclear antibodies, right? Anti-neutrophil antibodies. And so that's why if the antibodies are against the cytoplasm of your neutrophil, we are going to call it as C. Anka. We have another variant which is known as P. Anka. So what does the P. Anka stand? it's basically a perinuclear. What do you mean by perinuclear? That is around the nucleus. If we have antibodies that is basically targeting an area around the nucleus, so we are going to call it as perinuclear anti-neutrophil antibodies. Is that clear? So in Wagner granulomatosis, basically we are going to see C-ANCA. That is, the antibodies are going to be specifically present against the cytoplasm of your neutrophils. What else we are going to see? For example, if this is an individual, so simply you can just draw the letter C. The letter C. And what does this C indicates? You know, this C is going, it's passing through the upper respiratory tract, you know, it's passing through the lower respiratory tract, that is your lungs, and it's just coming out through your kidneys, right? So we are going to be seeing involvement of three important places, right? Inflammation. We are going to be having like problems of upper respiratory tract. We are going to be have problems with lower respiratory tract, and along with that, we are going to be having problems with kidney. So, for example, if we have an individual, he's having a kind of signs and symptoms of, sinusitis. Along with that, he's having cough. Let's suppose he's having wheezing along with some hematuria. So, what should be your diagnosis? That is three places are involved, right? Upper, lower, your lungs, along with that kidneys, right? So this is the main important feature of your Wagner granulomatosis, right? So Wagner granulomatosis is basically like, it's a kind of, you can imagine it's a kind of arthritis, right? So in Wagner granulomatosis, it's C-ANCA, right? It's also called as microscopic polyangiitis, okay? Is it clear? Okay. Then we have another variant as we discussed, Church-Strauss, right? So Church-Strauss is basically associated with P-ANCA. What do we mean by P-ANCA? Again, we are going to be having antibodies against the perinuclear area of that neutrophil, okay? And it's a granulomatous inflammation with eosinophils accompanied by asthma, right? That's really important. So let's discuss our next pathology. Okay, is that clear? Do you guys have any questions? Hello? Okay, so let's move to our next pathology, that is IgA nephropathy. Before discussing IgA nephropathy, can anyone just tell me IgA antibodies mainly provide immunity to which structures?
GI tract.
In the gym.
Can I say epithelial structures? Epithelial or mucosal structures?
Yes.
Yes.
Not only your GI, but your the mucosa of your respiratory tract as well, right? So IgA is basically going to, it's also known as Berger's disease, okay? So it's going to basically, the IgA is going to provide immunity to your mucosal surfaces. That's really important, right? So what happens in IgA nephropathy is that we are going to be having IgA immune complexes, right? IgA immune complexes, right? Okay, and where is the IgA present? We already know in the mucosal infection. So you can simply assume that this IgA nephropathy is going to be having, like, before the IgA nephropathy, before IgA complexes are formed and they enter into your kidney and activating your complement system, causing destruction. In the history, you must be having some kind of mucosal infections, right? Before that, like some mucosal infections. For example, gastroenteritis before that, right? So there will be a history of an individual having some, let's suppose, upper respiratory tract infection. After that, you have decline of his kidneys, having hematuria. So you should simply think of IgA nephropathy going on there, okay? So it's basically present during childhood, and you're going to be having episodic microscopic hematuria, right? So the hematuria is going to be episodic, and it's going to be preceded by some kind of mucosal infection. Is that clear?
Yes.
Okay, but as the immune complexes are formed containing IgA and some pathogens, right? So you should know that where do these complexes deposit within your glomeruli? So the answer for that is it would deposit in the mesenterium, right? We know what is mesenterium, right? We discussed that if you have your glomeruli basically have some kind of supporting cells, right? Which we call as mesenterial cells. If you remember the pathology which we discussed, that is membranous proliferative glomerulonephritis, in which your mesenterial cells were proliferating. That was and it was cutting through the intramembranous and giving you tram track appearance. Remember, so these are those mesenterial cells or mesenterium where your IgA antibodies are going to be attached, triggering an inflammation, causing nephrotic syndrome. Is that clear?
Yes.
Okay, let me just give you a quick overview again. IgA, whenever the word IgA come, you should imagine that it basically provides immunity to your mucosal surfaces. If you have IgA nephropathy, it means that before proceeding into nephrotic syndrome, you'll be having some kind of mucosal infections, right? And it's basically seen in children in the form of gross hematuria, right? This hematuria is going to be episodic, right? So there would be a history of episodic hematuria. That's really important to remember. Okay, so the last one of nephritic syndrome is going to be your Alport syndrome, right? And that's really easy. You guys know that the basement membrane basically is formed by which type of collagen? Yes.
Type
Type
4
4.
collagen.
Type 4 collagen. But type 4 collagen is not only present within that basement membrane. Type 4 collagen is present, in a lot of places inside your body, like in your eyes as well, in your ears as well, right? So in the ear, if you guys remember that we have, in your cochlea, basically we are going to be having like a lot of structures made of type 4 collagen, which we are going to discuss in our neurology section, right? So there I'll be just pointing out these. So what happens in Alport syndrome is that we are going to be having hereditary defect in which the type 4 collagen is going to be defective, right? So if the type 4 collagen is defective, simply you can imagine, right? For example, if this is your basement membrane and the type 4 collagen is defective. So won't we be seeing red blood cells moving out and some of the proteins moving out and having some kind of inflammation if we have that weakened, barrier due to defective type 4 collagen? Yes or no?
Yes.
Yes. So we will be having thinning of the glomerular basement membrane. Why? Because the type 4 collagen is the main component of your basement membrane, which is going to be weak, which is going to be defective, right? So thinning and splitting. So as the split, it can trigger inflammation, it can trigger the leak out of your red blood cells, giving you nephritic syndrome. Is that clear? Okay. So as we discussed, type 4 collagen is not only present within the glomerular basement membrane, but it's going to be accompanied by problems within the sensory hearing loss. You're going to have like ocular disturbances. So these two things are also going to be accompanied with the nephritic syndrome and Alport syndrome. That is sensory hearing loss plus ocular disturbances, right? Like there is a membrane in the eye, if you guys remember, that is a decimate membrane, right? Which is present in the lens behind the cornea. We are going to discuss that in detail in our neurology section. So that's the main thing. Okay, is that clear? Hello?
Yes.
Yes.
So this was all about your nephritic syndrome. Okay, so we have covered nephrotic syndrome, we have covered nephritic syndrome, and the next topic for today is going to be your nephrolithiasis. Okay, so what is nephrolithiasis? As the name indicates,
Kidney stone.
that is a kidney stone, simply, right? Kidney stone. So the question should arise in your mind that how can we get kidney stones? Okay, the answer for that is really simple. Whenever we have some kind of, we know that your urine basically consists of some particulate material as well, right? Some particulate material as well. So whenever we have precipitation of that particulate material, and that particulate material with time aggregates, and so it would lead to formation of a stone, which is going to be termed as nephrolithiasis, right? So there are different types of these nephrolithiasis stones, which we are going to discuss in the detail. But before that, you should know what would be the presenting feature if an individual is having nephrolithiasis, right? So the risk factor for development of nephrolithiasis is going to be like high concentration of solutes, high concentration of that particulate substances, which can precipitate, which can just aggregate together. It can just form that hard stones-like appearance. Okay, so the presenting feature is going to be hematuria. The idea is really simple. If you are going to be having certain kind of stone, it's going to keep on irritating the mesenchyme there. Okay, the mesenchymal tissue of your kidney, and it's going to trigger an inflammation. Inflammation in turn is going to lead to hematuria, right? Along with that, there is also going to be tenderness, right? Unilateral flame tenderness. The idea is really simple. If this is your kidney and you're having some kind of stones, you're going to be having, stasis of urine there, right? And as we have stasis, the kidney is going to stretch. And as the kidney stretch, this stretching of kidney is basically going to give you that pain. Okay? So stone is usually passed within hours. If not, then we are going to surgically remove it. That's quite simple, right? So let's discuss different types of kidney stones, right? The first one and the most common one are calcium oxalate and calcium phosphate strons. Okay, so as we know that it's the most common, like 80% of the strong, if you just see in the kidney, are going to be like, calcium oxalate and calcium phosphate strong. Okay, that's really important. Okay, what's the cause of development of these strons? The cause is basically idiopathic, right? Like idiopathic, if we, without knowing the reason, if we have a lot of calcium leaking out into your urine, right? If you have a lot of calcium leaking out, leaking out through your GFR, so this calcium is a kind of particulate material, particulate substance, particulate solute. They can aggregate sometime along with, joining with oxalate or phosphate, and they can lead to formation of these strons, right? Is that clear? Hello?
Yes.
Okay. Okay. So as we discussed, if you guys remember hypercalcemia, can hypercalcemia lead to strons? Yes. Right? If you have hypercalcemia, if you guys remember the mnemonic bones, groans, strons, and psychiatric overtones, right? So the strons was for kidney strons, right? Crohn's disease can also lead to, Crohn's disease can also lead to kidney strons. Who's going to be telling me the pathophysiology behind that? Yes. Crohn's disease. Hello. What is Crohn's disease, by the way?
Inflammatory bowel disease.
Chronic
Okay.
inflammatory disease.
It is due to
Okay.
the malabsorption of the nutrients.
Okay, perfect. So Crohn's disease
In the
basically,
fat,
which
particularly fat in the small intestine. Yeah.
perfect. So basically, which part of your GI is going to be
Terminal
affected with
ileum.
Crohn's disease?
Terminal ileum.
Terminal ileum. Perfect. Terminal ileum is going to be affected. And in the terminal ileum, basically, we have absorption of your, a lot of things. For example, we have absorption of fats as well, right?
Yes.
Hello?
Yes.
So
Yes.
if the
Yes.
fats aren't absorbing well due to inflammation, fats won't absorb well. So the fat-soluble vitamins are also not going to be absorbed there, right?
Yeah.
Yes.
The vitamins, fat-soluble vitamins are
A, D, E, and K.
A, D, E, K. D, E, and K.
Vitamin D. What's the function of vitamin D?
Absorption of
Calcium and phosphate absorption
calcium
from
in the
the small
GI.
intestine.
Okay. So absorption of your calcium, right?
Yeah.
If the calcium isn't reabsorbed, won't we be having a lot of calcium in the blood?
No.
Yes.
Hello?
Yes.
Yes or no? The calcium isn't getting reabsorbed. Hello?
It's affecting on both in
Yes.
intestine and kidneys, both.
Sorry? Okay. So in that case, we are going to be having kidney stones again, okay? Due to calcium oxalate and calcium phosphate stone. So what is going to be the treatment option for that? Treatment is going to be, yes. Anyone?
If we have like hypercalciuria, right? For example, if the kidney stones are formed due to hypercalciuria, it means you are going to lose a lot of calcium as well. Formation of those stones are going to lose calcium from your blood. And if you have hypercalciuria, that is the most common cause. Idiopathic hypercalciuria is the most common cause of calcium oxalate and phosphate stones. So what do you think would be the treatment option for this individual if you're losing a lot of calcium in these processes?
We give the thiazide
Okay.
diuretics, which
Perfect.
increase the calcium absorption.
Perfect.
So the
Thiazide diuretic.
calciuria will be reduced.
Perfect. That's great. Okay. So the next kind of stones are MAP stones, right? MAP. What do we mean by MAP stones? Magnesium, ammonium, and phosphate stones, right? So these are the second most common stones. And as we know, they are also known as infectious stones, right? Remember that. Infectious stones, right? So why do we call it as infection stones? Because the most common cause of formation of these kind of stones are basically it's caused by infection. Infection with which kind of organism? Who is going to be telling me that? Really important.
Urease positive organisms like
Perfect.
Proteus, E. coli, Klebsiella, Streptococcus saprophyticus.
Perfect. So what these urease positive microorganisms are going to do, they are going to produce an alkaline environment, right? Alkaline urine,
right? And this alkalinization of urine is going to lead to precipitation of your ammonia, magnesium, and phosphate, leading toward to the formation of stones, right? And what's the structure of the infectious stones? How would they present?
Staghorn appearance.
Perfect, staghorn, right? So it's going to be a big stones with like a staghorn appearance, right? So the treatment for it is always like surgical removal, right? Because it's a quite big stone. And why do we call it as staghorn? Because it resembles the staghorn, right? That's why we are just calling it as staghorn stones, right? So the staghorn or stones are also called as infectious stones, as we already discussed. Why? Because they are caused by an infection with urease positive organisms, leading to alkalization of urine. That alkaline environment is going to trigger the precipitation of your ammonia, magnesium, and phosphate, leading towards formation of that staghorn caliculi or staghorn stones. That's why we are going to call it as infectious stone. You can just call it as staghorn or MAP stones, magnesium, ammonium, and phosphate. Okay. Okay, and what other is going to be the treatment option? First of all, the surgical removal of staghorn, and the other thing is going to be treated with antibiotics.
Shockwave lithotripsy.
Sorry. Okay,
Shockwave lithotripsy.
lithotripsy can basically yes, you can say, but the best option is it's a big stone. We should be just surgically removing it. So remove the cause, remove the pathogen, right? So if you just remove the pathogen at first place, so this individual then is going to be less vulnerable to have MAP stones in the future. Okay, so next type of stone is uric acid stones. Okay, so looking towards the name, I think most of the things are going to be coming into your mind. First of all, are they radiopaque or are they radiolucents? Really important. You're going to be having a lot.
Radiolucent.
Uric acid
What do you
stone.
mean by radiolucent?
Because
You
they
cannot-
appear black on X-ray.
Yes, so you cannot basically see it on X-ray, right? So it's and the other stones are basically radio opaque. You can just see it on X-ray. So radiolucent basically means you can't pick it on X-ray. Okay. So what are the causes of uric acid formation? If you know the causes of increased uric acid formation, so then it's going to be like quite clear that why the stones are going to be formed, why the uric acid stone, right? So in severe hot arid environment, as we have a lot of cellular turnover, which can lead to formation of a lot of uric acid, it can lead to formation of uric acid stone. The gout as well. What happens in gout? If you guys remember, increased uric acid level, right?
Yes.
Okay. In myeloproliferative disorders, you have increased
Also in
cellular turnover.
chemotherapy, yeah.
Yes, chemotherapy is where if you are destroying the cells, basically uric acid come from metabolism of which bases? Urine bases, right? Urine or pyrimidine? Hello?
Urine.
Urine.
Right?
Urine.
Urine comes from DNA, right? So if any process which is leading to increased cellular turnover, for example, if you are killing the cell, you are just making a lot of DNA. It means you are going to make a lot of uric acid. A lot of uric acid going to lead into urine, giving you uric acid stones, right? And what is going to be the treatment for uric acid stone? First of all, if an individual is having uric acid stones due to gout, so which drug are we going to give?
Allopurinol.
Allopurinol, perfect.
Oxidase inhibitor.
Oxidase inhibitor, perfect. And treatment with hydration as well. It's a uric acid. It's a uric acid. So alkalinize the urine, right? Given alkaline environment, so it cannot precipitate. Okay. Hello.
Yes.
Okay. Then we have cysteine stones. What is cysteine, by the way? Hello.
Amino acid.
It's an amino acid. Perfect. It's an amino acid. So basically, we have certain transporters, not only within the kidney, but within your GI tract, that is going to transport certain amino acid. The mnemonic for that is COLA. Who's going to be telling me? One is the cysteine. What's the next?
Cysteine. Ornithine.
Ornithine. Lysine and arginine. Okay, so all of these amino acids are basically going to be transported through a single transporter, which is present within your kidney as well as your GI tract as well, right? So what happens if we have defective transport or the transporter? So what happens? A lot of cysteine is going to be dumped off in your urine. So only the cysteine can just lead to stone. Keep that in mind, because it isn't soluble in your urine. It isn't soluble in your water, right? So it will precipitate down. The other amino acids are easily soluble in the urine, that can just leak out. So the cysteine stone basically is going to be the rare cause of nephrolithiasis seen in children, right? And the idea is really simple. If we have problems with defective carrier protein, right? So it's mostly going to be seen in children, right? In the first phases of development, that is in a child age, right? So basically genetic defect, and as a result of that, okay, which kind? Staghorn caliculi as well. If you see Staghorn caliculi in a child, simply think of cystine stone, right? And if you have Staghorn caliculi in adults, what's going to be your diagnosis then?
Infectious.
Infectious MAP stones, right?
Infectious, yeah.
Perfect. So these were all about the kidney stones: calcium oxalate, MAP, uric acid, cystine. Do you guys want me to give you an overview, or that's clear? Hello?
Excuse me,
Give.
Dr. Ahmed, kindly clear me
Yes.
this concept of the Crohn's disease. There is the increased fat, so that fat gets bind with the calcium, and that because of malabsorption of that fat, that comes into the urine. The calcium tagged fat that comes into the urine that leads to the calcium stone formation.
Yes.
This is
Basically, the ADEK basically. So you have, the vitamin D is not going to be present there more, okay, because you cannot reabsorb it, right? So
yes.
less vitamin D is going to lead to, okay, what would happen to the level of calcium in the blood if you have Crohn's disease?
The calcium will be increased.
Calcium will be increased, right?
Yes.
If hypercalcemia leads to
Hypercalcemia leads to hypercalciuria too.
bones, grown stones, right? Bones, kidneys,
Mhm.
and stones, right? So
Mhm.
hypercalcemia is basically going to lead to this stones.
Stones formation. Okay.
Okay.
Okay. So what is the reason for the fat? If there is increased fat, what does the function of fat in that case in the Crohn's?
In Crohn's disease, basically,
Again,
we
yes.
won't be having, in Crohn's disease, we do not have reabsorption of fats.
Okay, that's the only the vitamin D ADEK problem.
Yes. So
Fat.
we do not get fats reabsorption. Along with that, the fat soluble vitamin cannot be
Fats,
reabsorbed.
Okay. Okay.
fats get attached to the calcium. Sponification occurs, yeah.
Yes.
Mhm.
Okay. So
Okay.
that's the reason. So let's discuss our next topic, that is going to be your chronic kidney disease, and last topic for today. And tomorrow we are going to finish off the infection along with some of. Okay. So I want you guys to read the this topic, that is urinary tract infection. That's really a simpler topic, right? So I want it's a kind of homework for you guys. Okay. So tomorrow I'll be only going through. You should just remember the bugs in urethritis, in cystitis. What is cystitis? What is pyelonephritis? That's quite simple. I'll be just going through, right? That, and tomorrow we are going to cover. We are going to spend a lot of time on the tumors, as well as we are also going to discuss the pharmacology as well, right? And with that, your renal system is going to be finished. After that, we are going to start our pulmonology. Okay. So what is CKD? Chronic kidney disease. Can anyone just tell me what is CKD?
Altered renal function for more than 3 months.
Oh,
CKD.
perfect. Chronic, more than 3 months. Good. Okay. So it's basically an end-stage kidney failure. Your kidney fails to function. If your kidney fails to function, if you know the normal function of the kidney, then you know the CKD, you know the normal function is going to be disrupted. Like, for example, you may be having, like, may result from glomerular tubular inflammatory, vascular insult. It can be due to hypertension. It can be due to diabetes. It can be due to glomerular disease. Anything, if exceeded more than its time, more than 3 months, is going to lead to CKD, right? So what would be the clinical features? What's the main, function of your kidney? That is going to excrete out your urea. If your kidney is, defective, if you have CKD, the urea won't leave. You're going to be having uremia, right? And uremia can lead to a lot of problems. If you guys remember, pericarditis, remember?
Encephalopathy and pancreatitis.
Yes, pancreatitis. Along with that, pericarditis, nausea, vomiting, platelets to platelet adhesion problem. The platelets to platelets adhesion is also going to be disrupted. We're going to discuss that in hematology section. You have a word MCQ on that as well. And as the urea increases, we are going to be having metabolic acidosis, remember?
Mm-hmm. Yes.
Enangium gap or non-enangium gap?
High NN gap.
High
Enangium
in
gap. We already discussed it, right? Okay. If the kidneys aren't functioning, the aldosterone won't undergo its function as well. Okay, so what would happen to the level of potassium?
Increase.
Increased height.
Increased.
Hyperkalemia.
Hyperkalemia.
Increased.
Perfect. If you remember, the peritubular capillaries have some interstitial cell, which basically releases EPO. Your kidney is failing to produce EPO as well. So what would happen as a consequence of that?
Microcytic anemia.
Anemia. Perfect.
Anemia.
Right? Your kidney is also important in hydroxylating your 25-OH vitamin D, right? In the proximal convoluted tubule, you have one alpha hydroxylase, which is influenced by your PTH. Remember it? Parathyroid hormone,
Yes.
right? So if you do not have proper hydroxylation of your 25-OH, so what would be the problem? Won't we be seeing
Vitamin D.
hypocalcemia?
Vitamin D will not be there, and the calcium will not be absorbed from the small
Okay.
intestine.
If
So we'll
form of
have,
vitamin D is not there, yeah.
perfect. So we'll be having hypocalcemia, and whenever we have hypocalcemia, so what are we going to see? We are basically going to see two things: Proju and Shostak sign. Remember?
Yes.
Okay, hyperphosphatemia, right? A lot of phosphate. Because phosphate is excreted out in the proximal convoluted tubule, again under the action of your parathyroid hormone, which is also called as phosphate tration hormone. Okay? Hello?
Yes.
And another
Yes.
thing, when we discussed it, can if you guys remember in our endocrinology, secondary
Hyperthyroid.
Secondary
Parathyroid.
parathyroid. And what's the pathophysiology behind that?
CKD. In the
Renal.
chronic
CKD,
renal
yeah.
failure, there will
Mhm.
be the low serum calcium level. That's the
Perfect.
negative feedback will be affected, and the
And high
parathyroid hormone will be released.
phosphate level.
Perfect. Whenever we have CKD, we have hyperphosphatemia, right? And we know that phosphate basically loves to bind with your calcium. So what this phosphate is going to do, it's going to, hold all of the calcium from the blood. So it's going to lead to hypocalcemia if the calcium is, held by your phosphate, hypocalcemia. And hypocalcemia is one of the trigger for the release of your PTH. So a lot of PTH being produced due to hypocalcemia, and the main reason behind that was your CKD. So it would just give you what? Secondary hyperparathyroidism. Okay. Hello.
Yeah.
If we have less vitamin D, won't we be having in a baby, or let's suppose in an individual, in an adult, it's going to give you osteomalacia, right? What is osteomalacia? Malaysia. Yes.
Reduce
Softening of the bones. Softening of the bone.
deficiency,
Okay. Yes, that's the problem with the bones. We're going to discuss that in our MSK. And the same due to vitamin D deficiency is seen in children. Then which pathology are we going to see?
rickets.
Rickets. Perfect. We are going to have
Rickets.
osteoporosis in adults as well, because calcium is important for your bones, right? Okay, so what is going to be the treatment option for CKD? That's quite simple. As we are having electrolyte disturbances, as we are having a lot of toxins being built in the blood, so the dialysis is a good option for that. But it isn't a permanent option, so we should be going towards renal transplant. Is that clear?
Yes.
Okay, so this was all about today's lecture. We are only left with the two topics. One of the topics is your homework. You guys are going to do it by your own. I'm only going to go through this topic, and tomorrow we are going to spend a lot of time on tumors. The tumors are really important. We're going to be having a lot of MCQs especially from the renal cell carcinoma on your real exam as well, right? So we will be spending some time on that, and we have some pharmacology. Pharmacology is very simple, right? We already know the transporter, we already know the physiology. I'm only going to name those drugs, and we would know that what's the function of these drugs. If we are blocking, channels within the ascending loop, if we are blocking channels within the distal convoluted loop, diuretics, thiazide diuretics, and everything, mannitol and everything, right? So it's going to be quite easy for you guys. So thank you so much for being here in the class. I really enjoyed having session with you guys, and maybe Dr. Moaz is also going to join soon in your pulmonology as they are traveling, so they're going to join soon. Or Dr. Mahin already have joined. So thank you so much for having such a patience, because we didn't have had classes with Dr. Mahin since long. Okay. So from tomorrow onwards, she's going to be regularly taking the classes. Thank you so much. Thank you, and have a nice day.
Thank you.
Please just leave this session so that we can just get the recordings, please.